Hello, everyone. My name is Matthew Jones. I'm one of the current primary care sports medicine fellows here at the DMC, and I will be presenting our quality improvement study titled Patient Check-in Quality Improvement Survey in a High Volume Orthopedic and Sports Medicine Clinics, and I'll be presenting on behalf of my co-authors today. For our project, we set our background as trying to evaluate for efficient patient check-in in our multiple clinics, and we know that efficient patient check-in is critical for smooth clinic flow, patient experience, and provider productivity. Our orthopedic and sports medicine offices require very specific complex check-in tasks, including insurance review, prior imaging review, and completion of many patient-reported outcome measures, or PROMs. Multiple prior studies have shown an inverse relationship with wait time and patient satisfaction. This includes wait times to check in, as well as wait times prior to rooming. Patient satisfaction decreases even when quality of this clinical care remains high due to these wait times. Orthopedic-specific studies have shown association between longer wait times and lower satisfaction scores, as well as a less likelihood to recommend scores. Operational metrics alone may not capture the key aspects of the patient experience, and identifying these aspects can create a targeted workflow improvement goal. This may include options such as streamlined intake processes, digital pre-visit check-in tools, and improved communication and staffing models. Analyzing our presumed problem with a fishbone diagram, we can see that many factors contribute to the check-in delays and reduce patient satisfaction, including our technology, which can include limited online pre-check-in, slow kiosks and tablets in the office, as well as EMR inefficiencies. There's also complex registration tasks, insurance verification, poor staffing or staffing factors such as friendliness, um, and then as well as multiple PROMs patients require, as well as patients being late, insurance and demographic changes. So the purpose and aims of our study. Our goal was to identify patient-reported barriers within the clinic check-in process in order to inform workflow improvements that reduce check-in to room placement time and improve patient satisfaction in our DMC orthopedic and sports medicine clinics. Our study design was a prospective quality improvement study utilizing a standardized survey to systematically collect patient-reported experiences, and was conducted across all of our orthopedic and sports medicine clinics here at the DMC. Our data collection used a standardized patient survey, which was administered prior to the clinical encounter. It was distributed via SurveyMonkey link, which was accessible by QR code or they were given a tablet while they checked into the office. Our survey questions collected demographic questions, satisfaction, and experience questions that were rated on a 1 to 4 scale, evaluated the perceived wait time, as well as which aspects patients felt needed the most improvement. So they were given a multiple choice selection between staff efficiency, wait time, clarity of instructions, and the technology or equipment. Here we have an example of our questions, including how they would rate their overall experience, how easy it was to find in the check-in, to locate the check-in area, and how satisfied they were with the friendliness and professionalism during check-in. Their perceived wait time was broken down into groups of 5 minutes to 10 minutes, and then how they would rate the information clarity provided during the check-in process. For our data analysis, our survey responses were stored on an institutional OneDrive server. We did not collect any any protected health information from the patients. And then for our data analysis, statistical data analysis included descriptive statistics and a chi-squared Pearson's test. The chi-square analysis was used to evaluate associations between the patient-reported check-in experience, the perceived wait time, and the overall satisfaction with the intake process. We also used a machine learning predictive model in analysis. So the machine learning based multi-layer perception neural network was used to build a predictive model to stratify the importance of each of the variables to the patient's satisfaction outcomes. So again, they were rated on broken down into satisfied versus not satisfied. Um, Both statistical analysis and the MPNN analysis were performed using a SPSS. For our results section, we found information on where the patients would like to wait, with the majority of them saying in the waiting room as compared to the exam room. We found that patients were, the wait time, majority of them were less than 5 minutes waiting to be checked in. But then the next biggest group was going to be the 5 to 10 minute group, and then 10% and 8% respectively for 11 to 20, and then greater than 20 minutes. For our analyses, anything marked by a star is going to be a statistically significant result here. And we found that patients that had the less than 5 minutes wait time were more likely to have um, a better overall clinical experience, with a p-value of 0.024. For when we rated the friendliness and professionalism of the staff during check-in, patients that were very satisfied felt that they had more excellent or good rating of our staff friendliness and professionalism, with a p-value of less than 0.001. For the satisfaction and clarity of the information provided during the check-in process, um, patients that perceived them as very clear also rated a greater overall experience. This was a p-value of 0.003. As far as our clinic locations, just looking at where our data came from, the majority of our answers came from both the CVI Detroit location and the Dearborn location, respectively, but also a significant amount of answers from Troy. But we did include both the Farmington and the Sterling Heights office. So for patient satisfaction related to the clinic location, we could see that the CVI, the Dearborn, and the Troy offices had a statistically significant um, overall experience, a greater overall experience, with a p-value of 0.06. And then when we analyzed what patient improvement requests were most likely selected, and it was going to be the overall wait time, with a overall percentage of 46.8%. Using the predictive model, the machine learning predictive model, we found that friendliness and professionalism of the staff during check-in is the most important factor to contributing to patient satisfaction. Moving on into our discussion. For our barriers to patient satisfaction, we were looking at the friendliness and professionalism of our staff, which our patients found to be predominantly friendly and professional. We found that our information was clear for the majority of patients. We also found that the overall location of the check-in was determined to be easy to find for patients. We also found that patients did not experience significant technical issues while checking in, but we did find that patients who waited less tended to have a better overall satisfaction score. For our machine learning predictive model for medical research, just as a background, we know that AI and machine learning prefers large data sets, but there has been shown that you can use small data sets for building prospective models. These predictive modeling has to be done with a simplicity first approach when using these small medical data sets. And by prioritizing regularization through cross-validation and interpretable outputs, we can extract insights of a stratified importance of factors contributing to clinical data. Overall, while we studied variables were statistically significant, we found wait time, professionalism, and friendliness of staff to be the most important contributing factors to patient satisfaction. A few potential confounding variables included clinic flow changes, staffing levels at different clinics, provider delays, imaging delays, variability in the clinic volume per provider, differences in visit types. Some survey-related variables included completing the survey increased that perceived time of check-in. Environmentals, clinics with easier parking situations, decreased that frustration with finding the check-in spot. And there's always temporal delays such as time of the day of the week, seasonal sporting sessions as well. Strengths of our study included a multi-clinic, multi-provider study. We focused on patient-centered outcomes. It was low cost and very easily reproducible, and included a prospective design. Limitations included possible selection bias. Sampling was not random, as patients needed to be willing to respond. Lack of a control comparison group, and limited information on workflow, staff flow. In the future, we'll continue to gather data throughout our sports medicine and orthopedic clinics, as we're going to continue the survey through the month of March. We're going to focus data on optimizing breakdowns in clinics with lower patient satisfaction scores. Thank you for listening.